Boys and girls, today I'll be taking drug distribution. Before we start the class, let us see the learning objectives for this drug distribution. So what are we going to learn? So we'll be learning about the distribution of drugs across various body compartments. Then we'll be throwing some light on apparent volume of distribution, and then the clinical significance of drug distribution. Apart from that, we'll also discuss about plasma protein binding, and then the clinical significance of plasma protein binding of drugs. And then we'll throw some light on redistribution of drugs with clinical application as well also. So in a previous class, you have learned about how drugs are administered. What are the various methods of routes of administration of drugs, wherein we have seen the drugs are administered through enteral, parenteral, as well as topical. But what happens to these drugs when they are what happens to them after administration? So they need to be absorbed, and then after absorption they need to be distributed. So here in this picture you can see, where do these drugs go? So drugs are administered either by enteral, parenteral, or through topical, whatever. And then after absorption, the concentration of the drug in the systemic circulation is increased. So this drug has to get distributed to the organs of choice or to the tissues for action. So drugs are administered, absorbed, concentration in the systemic circulation, they're distributed, and drugs in the tissues are distributed. So as you can see in this picture, administration enter the bloodstream, distribute to the tissues. Well, once the drug has gained access to the bloodstream, it gets distributed to other tissues that initially had no drug. So you take the drug either orally or parenterally, then it gets absorbed and it gains access to the bloodstream, from where it is distributed to the tissues which have no drug initially. The drug can be distributed to one or more compartments. Distribution may be uniform or ununiform or selective or unselectively, evenly or uneven. Distribution may be uniform or may not be uniform. It may be evenly or unevenly or selectively distributed in different body compartments. More of the drug is distributed, it becomes diluted. Less distribution, there is increased concentration of the drug. So once the drug has given access to the bloodstream, so once the drug is taken in or once the drug is administered, it gets distributed to other tissues. It gets access to the bloodstream and gets distributed to other tissues that initially had no drug. So the drug can be distributed to one or more compartments. Distribution may be uniform, or may not be uniform. It may be evenly or unevenly or selectively distributed to different body compartments. More of the drug is distributed, the drug becomes diluted. Less of the drug will reach, less contribution, so more concentration of the drug is available. So let's see the factors affecting distribution. So lipid solubility plays a role, ionization molecular size, and then binding to plasma, tissue and proteins, presence of tissue-specific transporters, and then differences in regional blood flow. So these are the factors which govern distribution. So see in the picture, lipid solubility, ionization molecular size, and then binding to plasma and tissue protein, presence of tissue-specific transporters, and then differences in regional blood flow. These are a couple of factors which govern distribution. So the extent of drug distribution and pattern of tissue distribution depends on its, as we've learned a couple of minutes back, on lipid solubility, ionization at physiological pH, extent of binding to plasma and tissue proteins, presence of tissue-specific transporters, and then differences in regional blood flow. So these all govern drug distribution. So distribution of drugs in different physiological compartments. Now let's look at the distribution of drugs in various physiological compartments. In body compartments, in body water, drugs like ethanol, and then extracellular space, D-tuberculin, gentamicin, D-tuberculin, gentamicin, iodine, bromine, chlorine, sodium, and calcium are a couple of drugs which are distributed in extracellular space. Intravascular, dextran and heparin, and intracellular, sucrose. In various other tissues, like in body fat, thiopentone and DDT, bones, fluoride, liver, chloroquine and vitamin A, thyroid, iodine, skin, glycofulvin. So these are the various physiological compartments wherein the drugs are distributed. So we have seen in body compartments as well as in other various tissues. Physiological barrier to drug distribution. So what are the physiological barriers to drug distribution? So one such thing, blood-brain barrier. So drug administered to bloodstream do not always get free access or passage to brain because blood has got its own protective mechanisms. So whatever drugs we administer do not get that easily accessibility into the brain because blood has got a protective mechanisms which prevents intrusion of toxic substances. So these are the physiological barriers to drug distribution. So these are some of the physiological barriers to drug distribution. As I've told you, drugs administered to bloodstream do not always get free passage to brain because brain has got some protective mechanisms which prevent intrusion of toxic substances into the brain. So what are the physiological barriers to drug distribution? So anatomical barriers are blood-brain barrier. This is mainly constituted by capillary endothelial cells joined by tight junctions. So one such barrier is an anatomical barrier which the brain has developed itself, or brain has got some protective mechanisms like anatomical barriers. So this is called as blood-brain barrier, which is constituted by capillary endothelial cells joined by tight junctions. So these capillary endothelial cells are enveloped by pericapillary glial cells. So these pericapillary glial cells, they envelop the capillary endothelial cells. So this morphologically constitutes blood-brain barrier. So blood-brain barrier is constituted by capillary endothelial cells joined by tight junctions. So these capillary endothelial cells are enveloped by glial cells. And this constitutes morphologically the blood-brain barrier. So this blood-brain barrier places certain constraints on passage of drugs from blood to brain and the cerebrospinal fluids. So as I've told you, brain has developed some protective mechanisms. So one such is anatomical barrier. So it is otherwise called as blood-brain barrier, which is constituted by capillary endothelial cells joined by tight junctions. So these capillary endothelial cells are enveloped by glial cells, pericapillary glial cells. So this constitutes the blood-brain barrier, or this is morphologically called as the blood-brain barrier. The blood-brain barrier places certain constraints on passage of drugs from blood to brain and CSF. So apart from this, apart from anatomical barriers, we have functional barriers as well. So efflux transporter located at blood-brain barrier complement it and protect brain from toxic substances. So apart from having anatomical barriers like blood-brain barrier, there are some efflux transporters which are useful in throwing out toxic substances. So efflux transporters like P-glycoprotein and anionic transporters, OATP, or organic anionic transporting polypeptides on brain and choroid vessels which expel out unwanted substances. So brain has developed some functional barriers as well. There are some functional barriers as well as in brain which efflux, which throws out unwanted substances or toxic substances from the body. So there are some transporters called as efflux transporters. So they are located in the blood-brain barrier and they complement it and protect brain from toxic substances. So efflux transporters like P-glycoprotein and anionic transporters OATP on brain and choroid vessels, they are useful in expelling out unwanted substances. And enzymatic mechanisms like MEAO and cholinesterase, etc., they also prevent entry of neurotransmitters in the brain. So we have barriers like anatomical barriers. So this constitutes. So there are some protective barriers which the brain has developed. So they have got some protective mechanisms like anatomical barriers and functional barriers. So anatomical barriers, it constitutes blood-brain barrier. So this is constituted by capillary endothelial cells joined by tight junctions, as I've told you. So these capillary endothelial cells are enveloped by pericapillary glial cells. So thus this morphologically constitutes a blood-brain barrier. So this blood-brain barrier mainly constrains the passage of drugs from blood to brain as well as cerebrospinal fluid. So apart from this anatomical barrier, we have functional barriers as well. So what is the function of these functional barriers? So they're mainly useful in throwing out toxic substances from the brain. So we have transporters like P-glycoprotein as well as OATP on brain and choroid vessels which expel out unwanted substances. Apart from this, there are some mechanisms like enzymatic mechanisms which also prevent entry of neurotransmitters into the central nervous system. So enzymatic mechanisms like MAO and cholinesterase, they prevent entry of neurotransmitters into the central nervous system. So only lipid-soluble, non-ionized form of drugs penetrate more easily to brain as compared to water-soluble, ionized form of drug. So only lipid-soluble drugs have the accessibility into the brain as much when compared to water-soluble and ionized form of drug. In inflammatory conditions like cerebral meningitis, this condition, so the permeability of blood-brain barrier usually alters. So drugs like penicillins, chloramphenicol, which otherwise have poor penetration, exhibit increased permeability through blood-brain barrier. So this condition can be altered once the inflammatory conditions are reduced. So only lipid-soluble, non-ionized form of drugs penetrate more easily to brain as much when compared to water-soluble, ionized form of drugs. But in inflammatory conditions like meningitis, cerebral meningitis, usually they alter. So the blood-brain barrier permeability to such drugs like penicillin, chloramphenicol, which otherwise have poor penetration, exhibit increased permeability to blood-brain barrier. So once the inflammation conditions are reduced, so this thing will be restored. The permeability will be restored back. So there are 5 regions in the brain which are relatively permeable and thus do not constitute part of blood-brain barrier. So as I've told you, blood-brain does not easily allow ionized or water-soluble compounds. Only high lipid-soluble and non-ionized compounds are allowed. And blood-brain barrier constitutes an anatomical barrier as well as a functional barrier. But there are a couple of regions in the brain wherein the drugs can easily get permeability. And let's look at what are the 5 regions of the brain which are relatively permeable and which do not constitute part of blood-brain barrier. They are mainly pituitary gland, pineal body, median eminence, choroid plexus capillaris, area postrema near floor of fourth ventricle, which includes CTZ and vomiting center. So, placental barrier, so mainly found by layer of trophoblastic cells in chorionic villi. Also, as it is also a lipid membrane, acts the same way as other membranes. So just now we have learned that brain has access to lipid soluble drugs. So as this membrane is also a lipid membrane and acts same as other membranes. It transports nutrients and some drugs by active transport and carrier-mediated transport mechanisms. So drugs across the membrane are transported by active transport as well as by carrier-mediated transport mechanisms, but depends on maternal fetal placental gradient factor. So mainly the placental barrier are formed by layer of trophoblastic cells in chorionic villi. It is a lipid membrane and acts same as other membranes. Transports nutrients and some drugs by active as well as by carrier-mediated transport mechanisms. But then it depends on maternal fetal placental gradient factor. There are some influx transporters as well in placenta. So it is called as an incomplete barrier. So apart from these barrier mechanisms, there is also an incomplete barrier. But there are some influx transporters into the placenta, and hence it is called as an incomplete barrier. So precautions must be taken while prescribing drugs during pregnancy. So one should take precaution while you administer drugs. So when you administer drugs during pregnancy or when you prescribe drugs during pregnancy, consider all the drugs to be teratogenic unless they are proved to be safe. Never ever administer a drug unless until it is proved to be safe. So there are some influx transporters also in placenta, and hence it is called as an incomplete barrier. So precaution must be taken while prescribing drugs during pregnancy. All the drugs should be considered as teratogenic unless until they are proved to be safe. In addition, other transport mechanisms also exist in placenta. They're mainly active transport as well as penocytosis. And apart from this, P-glycoprotein acts as an exporter of various toxic agents and drugs and thus prevents the fetus from exposure to these toxic agents. So the passage of drugs to placenta in the fetus circulation is determined by the properties of the placenta. So there are various factors which determine the passage of drugs through the placenta into the fetus circulation. And they are the properties of the placenta, properties of the drug, and then the altered maternal blood levels due to changing pharmacokinetics in pregnancy. So these are some of the factors which determine the passage of drugs into the through the placenta into the fetal circulation. They are mainly the properties of the placenta, properties of the drug, and then the altered maternal blood levels due to changing pharmacokinetics in pregnancy. So let's see special compartments for drug distribution. So we have like cellular reservoir, fat as a reservoir, transcellular reservoir, and then bones and connective tissue reservoirs, and then plasma protein binding as drug reservoir. So let's discuss in detail about cellular reservoir. So drugs may have greater affinity for plasma proteins and yet be primarily distributed tissues. So this is, if tissues have an higher affinity for the drug. So drugs may have greater affinity for plasma proteins and yet may be distributed tissues because owing to a higher affinity for the drug, so this thing is seen. So drugs like, for example, drugs like digoxin in skeletal muscles, heart, liver, and kidney, bound to muscle proteins. So as I've told you, drugs may have greater affinity for plasma proteins, but yet they are mainly distributed or in the skeletal muscles or to other muscle proteins or other tissues. So like digoxin in skeletal muscles, heart, liver, and kidney, mainly bound to muscle proteins. Iodine in thyroid, chloroquine, liver, and retina. Chloropropin is nice. So drugs may have greater affinity for plasma proteins. Yeah, they may be primarily distributed in tissues. So this occurs if the tissue has gotten higher affinity or greater affinity for the drug. Example, digoxin and amitin in skeletal muscles, heart, liver, and kidney, bound to muscle proteins. And then iodine in the thyroid, chloroquine in liver tissue, and retina. So these drugs, they have got affinity for plasma proteins, but they have got even more higher affinity for other proteins in the tissues. So this is how we see. So not only the plasma proteins, they act as reservoir, but even the cells or the tissues may also act as reservoir. So thereby, these drugs get distributors to the various tissues in the body. The fat also acts as a reservoir. So highly lipid soluble drugs like thiopentone and DDT get selectively accumulated in fat as well as in adipose tissue. So not only the cells, but even fat also acts as a reservoir. So drugs like thiopentone and DDT, which are highly lipid soluble, get selectively accumulated in fat and in adipose tissue. Fat is sluggish reservoir due to less blood flow. So as such, fat is a sluggish reservoir because less of blood supply or less of blood flow is there to the fat. So if body fat starts depleting during starvation, so the stored drug may be mobilized. And hence the increase in drug and leading to toxicity. So fat is a sluggish reservoir due to less blood flow. So unlike other reservoirs like cellular or connective tissues, this fat is a sluggish reservoir because of less blood flow. But if body starts depleting during starvation, whatever the drug which is stored in the fat may be mobilized, leading to toxicity. Transcellular reservoir. So drugs like chloramphenicol and prednisolone are stored in aqueous humor, and amino sugars in the CSF, endolymph and joint fluids, drugs like ampicillin, and then pleural fluid, imipramine. So this is transcellular reservoir, where a couple of drugs are deposited or stored, like drugs like chloramphenicol and prednisolone in the aqueous humor, and amino sugars in the CSF, ampicillin in endolymph and joint fluids, and then imipramine in the pleural fluid. Bones and connective tissue reservoirs. Drugs like tetracycline, cisplatin, lead, arsenic, fluorides, which form complex with bone and salts, get deposited in bone, nails, and teeth. And antifungal drugs like rhizophlavin, which has got higher affinity for keratin. Drugs like drugs like rhizophlavin has higher affinity for keratin precursor cells like skin and fingernails. So drugs like tetracycline, cisplatin, lead, arsenic, fluorides, which form complex with bones and salts, get deposited in bones, nails, and teeth. And rhizophlavin, being an antifungal drug, has affinity for keratin precursor cells and hence get deposited in skin and fingernails. Now let's see what is plasma protein binding, its clinical significance. So after the drug gets absorbed, the drug circulates in the systemic circulation in two forms, either in the free form or bound form. So free form, it is only a free fraction of a drug which is pharmacologically active. So as I've told you, after absorption, the drug circulates in systemic circulation to form, be it a free form or a bound form. So the free form is only a fraction of a drug which is pharmacologically active, which can diffuse to the capillary wall, gets metabolized and excreted through the glomerulus. So drug after distribution, which circulates in the system, in the blood, is in two forms, in free form or either bound form. The free form is only a fraction of a drug which is pharmacologically active, which can diffuse to capillary wall, gets metabolized and excreted through glomerulus. So bound form bind to plasma proteins, either albumin or alpha-1 acid glycoprotein. Drugs which bind to plasma and cellular proteins drugs bind to plasma and cellular proteins in a reversible manner and in a dynamic equilibrium. So as you can see here, drugs bind to plasma and cellular proteins, and this is in a reversible manner, and it is in equilibrium. It is in dynamic equilibrium. So free drug plus protein, so forms drug-protein complex. So we have discussed in detail about the two forms of drug, so free form and bound form. The bound form mainly binds to plasma proteins, so mainly albumin or alpha acid glycoprotein. So this drug binds to plasma and proteins in a reversible manner and is in a state of dynamic equilibrium. So free drug plus protein forms a drug-protein complex. So this is called as protein-bound component. So this protein-bound component is inert, not accessible to capillary diffusion, metabolism, as well as excretion. On the other hand, we have seen that free fraction of the drug is can diffuse, undergo metabolism, and gets excreted. And it is moreover pharmacologically active, whereas the protein-bound component, so the free drug plus the protein forms a drug-protein complex. This is called as protein-bound component. It is inert, it is not active, and does not have EC accessible to capillary diffusion, and does not undergo metabolism, and is not excreted. So what happens when there is extensive protein binding? So this does not prevent drugs from reaching its site of action, but only prolongs the drug availability. So whenever there is extensive protein binding, this does not prevent drug from reaching its sites of action, but only prolongs the drug availability and then prolongs the duration of action of the drug. As free or unbound drug is eliminated from the body, more drug dissociates from drug-protein complex to replace free drug that was lost. So as we have seen, we have free drug as well as bound drug. So as free or unbound drug is eliminated, so extensive protein binding does not prevent drug from reaching its sites of action, but only prolongs the drug availability and the duration of action of the drug. As free or unbound drug is eliminated from the body. So as free drug or unbound drug is eliminated or gets eliminated from the drug, more of the drug dissociates from drug-protein complex. So in last slide, we have seen that drug plus protein forms drug-protein complex or protein-bound component. So this protein-bound component, from this protein-bound component or from this drug-protein complex, more of the drug dissociates to replace the drug which was lost, that which is lost. So as free or unbound drug is eliminated from the drug, more drug dissociates from drug-protein complex to replace free drug that was lost. So it's like simple. in a battlefield, if the soldier is killed, so more of the soldiers they come to replace the killed soldier. So as free or unbound drug is eliminated from the body, more drug dissociates from drug protein complex to replace the drug that was lost. So simple, a person who is eliminated, the next person takes his place from the complex or from the group, from that store. So it's like that. As free or unbound drug is eliminated from the body, more drug dissociates from drug protein complex to replace free drug that was lost. Association and dissociation between drug and plasma protein is usually rapid. Association as well as a dissociation between the drug and the plasma protein is usually rapid. Albumin is the main binding protein for many endogenous substances and drugs. So as we have discussed just now, the main proteins are albumin as well as alpha-1 acid glycoprotein. But albumin is the main binding protein for many endogenous substances as well as many drugs. Acid drugs generally bind to plasma albumin, whereas basic drugs bind to alpha-acid glycoprotein. So the association and dissociation between drug and plasma protein is usually rapid. Albumin being the main binding protein for many endogenous substances and drugs. And acid drugs generally bind to plasma albumin, whereas basic drugs bind to alpha-acid glycoprotein. So as I've told you just now, the two important proteins are albumin as well as alpha-1 acid glycoprotein. So let's discuss about plasma albumin in detail. Acid drugs, mainly warfarin, penicillin, sulfonamide, salicylic acid, bind to albumin. And albumin has got two binding sites, namely site 1 and site 2. So acid drugs like warfarin, penicillin, sulfonamide, salicylic acid bind to albumin. As I've told you, acid drugs bind to albumin, whereas basic drugs bind to alpha-1 acid glycoprotein. And this albumin has got two binding sites, site 1 and site 2. Site 1 being less specific in binding, binds structurally to unrelated drugs like warfarin, sulfonamides, phenytoin, etc. On the other hand, site 2 is more specific and binds with acidic drugs, example probenecid, cloxacillin, and then naproxen. Drugs that bind both at site 1 and site 2. So there are some drugs which bind on the site 1 as well as the site 2, namely salicylic acid, indomethacin, and then glaveneclamide. Alpha-1 acid glycoprotein. So basic drugs like quinidine, imipramine, lignocaine, chloropromazine, propranolol bind to it. Plasma alpha-1 acid glycoprotein is an acute phase reactant protein. So its plasma concentration increases in physiological stress and in pathological states like MI, Crohn's disease, etc. So basic drugs, they mainly bind to alpha-1 acid glycoprotein, and drugs like quinidine, imipramine, lignocaine, chloropromazine, propranolol do bind to it. Plasma protein. Plasma alpha-1 acid glycoprotein is an acute phase reactant wherein its plasma concentration is increased in physiological states, physiological stress, and in pathological states like MI, Crohn's disease. Tissue proteins and nucleoproteins. So drugs having high apparent volume of distribution bind to tissue proteins. So drugs which have got high apparent volume distribution, they bind to tissue proteins. Example, digoxin, emitin, chloroquine. So we have discussed in couple of slides back, the drugs have, apart from having plasma protein binding, they also have higher affinity to tissue proteins. So drugs like digoxin, emitin, chloroquine, apart from having plasma protein binding, they also have got higher affinity to tissue proteins, and hence they get deposited in tissue proteins. Drugs like digoxin, emitin, and chloroquine are some of these drugs which have got which are bound to tissue proteins. And miscellaneous binding proteins. Steroids bind to corticosteroid binding globulin, transportin. Thyroxine binds to alpha globulins. So we have discussed in detail about special compartments for drug distribution. namely cellular reservoir. And then we had thrown some light on fat, which also acts as a reservoir, and then transcellular reservoir, and then bones and connective tissue reservoirs, and plasma protein binding as drug reservoir. And plasma protein, so mainly two proteins which plays an important role in binding these drugs. They are albumin and alpha-1 acid glycoprotein, and we have discussed about albumin and its binding sites also. Now that we are done with plasma proteins, let's see the clinical significant aspects of plasma protein binding. Highly plasma protein bound drugs remain restricted to vascular compartments. So highly plasma protein bound drugs, they mainly remain restricted to the vascular compartments, tend to have low volume distribution. Those drugs which are highly plasma protein bound are restricted to vascular compartment, and hence they have low volume of distribution. Highly plasma protein bound drugs are difficult to be removed by dialysis and need some special techniques for treatment of poisoning. Plasma protein binding is a capacity limited and it is a saturable process. So in disease states, in liver disease, in states like in liver disease, uremia and hypoalbuminemia, even a therapeutic doses can lead to high free drug concentration because of reduced plasma protein binding. So in liver disease, uremia, as well as in hypoalbuminemia, even small doses or even drugs when they are taken in therapeutic doses can lead to high free drug concentration because of reduced plasma protein binding. In physiological stress, MI, Crohn's disease, plasma concentration of alpha acid glycoprotein increases. Binding of basic drugs like propanol and quinidine increases in such pathological states, thereby decrease free concentration of drugs. So in physiological stress like MI, Crohn's disease, plasma concentration of alpha acid glycoprotein increases. So in these states, or in a state like in a condition like physiological stress, myocardial infarction, Crohn's disease, what happens? There is increased plasma concentration of alpha-1 acid glycoproteins. What happens when there is increased alpha-1 acid glycoprotein? There increased binding of basic drugs like propanol and quinidine. So when there is increased binding of these drugs to alpha-1 acid glycoprotein, there is decreased free concentration of drugs. So this is seen in such conditions. So in a condition or in a state like in a physiological stress or MI or Crohn's disease, the plasma concentration of alpha-1 acid glycoproteins increases. So what happens when there is increased alpha-1 acid glycoprotein? So binding of basic drugs like propanol and quinidine is increased because the plasma concentration of alpha-1 acid glycoprotein is increased. So whenever there is increased alpha-1 acid glycoprotein, the binding of basic drugs like propanol and quinidine also increases. So such increase in such pathological states causes decrease in free concentration of drug. So more than one drug can bind to same site of albumin. So at a time, more than one drug can bind to same site of albumin. So this can give rise to displacement interactions. So when there is binding of more than one drug to same site of albumin, this gives rise to displacement interactions, wherein drug bound with higher affinity displaces one with lower affinity. So there are binding sites on the albumin. As I've told you, it has got site 1 and site 2. So when more than one drug bind to the same site in albumin, so the drug with higher affinity displaces a drug with lower affinity. So displaces one with lower affinity. Acid drugs do not displace basic drugs and vice versa. And displacement reactions are rare with basic drugs. So as we see with albumin, it has got binding sites, and when more than one drug bind to the same site in albumin, This gives rise to displacement reactions, wherein drug with higher affinity displaces the drug with lower affinity. As the drugs do not displace basic drugs and vice versa. And displacement reactions are very rare or rare with basic drugs. Phenylbutazone salicylates sulfonamides displace tolbutamide from its binding sites, leading to hypoglycemia. So as we have seen here, when more than one drug can bind to same site of albumin, this can give rise to displacement interactions, wherein drug bound with higher affinity displaces one with lower affinity. So an example for this, phenylbutazone salicylates and sulfonamides displace tolbutamide from its binding site, leading to hypoglycemia. So tolbutamide being a oral hypoglycemic agent, so it causes hypoglycemia. So all these drugs, phenylbutazone, salicylates, and sulfonamides, and tolbutamide bind to albumin. But these drugs, phenylbutazone, salicylates, and sulfonamides, have got higher affinity when compared to tolbutamide, and hence they displace tolbutamide from its binding sites. So what happens when the drug is displaced from its binding site? There is increased concentration of the drug in the plasma, thereby leading to hypoglycemia. Salicylates, indomethacin, phenytoin displace warfarin results in increased risk of hemorrhage. So these drugs, salicylates, indomethacin, phenytoin, and warfarin, they also bind to the same binding site. But drugs like salicylates, indomethacin, phenytoin have got higher affinity to the binding site, and hence they displace warfarin from the binding site, and there is increased warfarin in the plasma, resulting in increased risk of hemorrhage. Sulfonamides and vitamin K displace endogenous ligands like bilirubin from protein binding sites, leading to kernicterus in neonates. So drugs like sulfonamides and vitamin K, they displace endogenous ligands like bilirubin from protein binding sites, leading to kernicterus in neonates. So these are a couple of drug protein clinical significance of plasma protein binding and displacement reactions, which we see with plasma proteins, drugs binding to plasma proteins. So apparent volume distribution. So volume that would be required to contain all of the drug in the body at the same concentration measured in the plasma, or volume into which the total amount of a drug in the body appears to be uniformly distributed to provide the concentration of the drug actually measured in the plasma. So what happens here? The total amount of a drug in the body appears to be uniformly distributed to provide the concentration of the drug actually measured in the plasma. So apparent volume distribution is measured by total amount of, is calculated by total amount of administered drug and by concentration of drug in plasma. So larger value of volume distribution indicates that larger quantity of drug is present in extravascular tissue. So more the value of volume of distribution, larger the quantity of drug is present in the extravascular tissue. Clinical significance of apparent volume distribution. Non-ionized lipid-soluble drugs easily cross membranes and are distributed throughout the body. They have large volumes of distribution. A drug does not cross capillary walls like high molecular weight compounds like heparin and insulin unless lipid-soluble drugs which are given by IV. Apparent volume distribution is equal to plasma water, that is 3 liters. Drugs highly bound to plasma proteins and less tissue binding or ionized drugs remain largely within vascular compartment and have very low apparent volume of distribution. On the other hand, less plasma protein binding drugs have high volumes of distribution. Example, chloroquine. Apparent volume distribution for many drugs may be much more than actual body volume. Such drugs are difficult to be removed by hemodialysis if toxicity appears. Example, digoxin, imipramine. Dialysis is fruitful for only drugs with small apparent volume of distribution. Example, warfarin and aspirin. Drugs with small apparent volume distribution, less protein binding is easier to be removed by dialysis. A value of apparent volume distribution less than 5 liter implies drug is retained in vascular compartment. Example, heparin, insulin, warfarin. Apparent volume distribution of approximately 50 liter implies drug restricted to extracellular fluid. Example, aspirin as well as tolbutamide. Larger the volume of apparent volume distribution, that is more than 20 liters, indicates distribution throughout total body with water. Example, ethanol, phenytoin, sodium, or penetration to various tissues. Example, digoxin, imipramine. In pathological states like CHF, uremia, cirrhosis of liver, this can alter apparent volume distribution of many drugs by altering distribution of body water as well as protein binding capacity. So redistribution. What is redistribution? So highly lipid soluble drugs get initially distributed to organs with high blood flow. So drugs which are highly lipid soluble, they get easy accessibility to organs which have got high blood flow like brain, heart, kidney, etc. Latter, less vascular but more bulky tissues take up the drug. So initially they are taken up by the highly lipid, they're taken up by the tissues which have got high blood flow and which have got high lipids, high blood flow, like brain, heart, and kidneys. So later on, these drugs are taken up by less vascular but more bulky tissues, like muscle and fat. Plasma concentration falls and drug is withdrawn from high perfused sites. So initially, high lipid soluble drugs get easy accessibility, or they get distributed easily to organs with high blood flow, that is brain, heart, and kidneys. Later, less vascular but more bulky tissues take up the drugs, like muscles and fat. So this is nothing but redistribution. So what happens here? There is falling plasma concentration and the drug is withdrawn from highly perfused sites. So if site of action of drug was in one of the highly perfused organs, redistribution results in termination of drug action. So initially, the highly lipid soluble drugs get easily accessibility or get distributed easily to organs with higher blood flow. And then less vascular but more bulky tissues take up the drugs. So what happens here? There is falling plasma concentration and the drug is withdrawn from highly perfused sites. So if site of action of drug was in highly perfused organs, suppose the site of action was to be in highly perfused organs, so the redistribution results in termination of drug action. So initially the drug was in high perfused organs, later on the drug is moved to less perfused organs are taken up by less vascular but bulky tissues, and hence plasma concentration falls and the drug is withdrawn from highly perfused sites. So site of action of drug which was supposed to be in highly perfused organs is redistributed and hence results in termination of drug action. So greater the lipid soluble drug, faster is redistribution. For example, thiopentile sodium. So this is a general anesthetic being lipid soluble. So thiopentile sodium, which is a highly lipid soluble compound, enters brain very rapidly in one circulation time, that is 1 minute after IV injection, causing general anesthesia. So thiopentile sodium is a barbiturate which acts as a short general anesthetic. So thiopentile sodium being lipid soluble enters the brain very rapidly. So it has got easy accessibility to the brain, and then it diffuses out of brain and gets redistributed in muscle fat, and then the action is terminated. So very short acting. So this is nothing but redistribution. Initially, it gets accessible to the brain and gets redistributed in muscle fat. And then we have got very short action. So thiopentile sodium being highly lipid soluble, they get access to the brain. But apart from this, because they're highly lipid soluble, they also diffuse out of the brain through blood circulation, and hence they are redistributed in the muscle, lean tissues as well as in the fat. So this thiopentosodium being lipid soluble enters brain very rapidly, causing general anesthesia. But being thiopentosodium being highly lipid soluble, they also diffuse out of the brain through blood circulation and are redistributed in muscle fat, and hence the action is terminated, and hence it has got hence it is very short acting. So repeated and continuous administration over longer periods is a solution for this. So if at all you want to carry out the anesthetic effect, so repeated and continuous administration over longer periods should be given. Hence lower perfusion, high capacity sites get progressive filled up, and hence long acting. So repeat and continuous administration longer periods, there is high capacity sites get progressive filled up, causing long acting. So this is called as redistribution. So over here in redistribution, highly lipid soluble drugs get initially distributed to organs with high blood flow like brain, heart, and kidneys. And then they also diffuse out of the brain through blood circulation and are redistributed in the muscles, fat, etc. So highly lipid soluble drugs get initially distributed to organs with high blood flow, brain, heart, kidneys. And then they also diffuse out of the brain through circulation and are redistributed to muscle fat. Muscle fat take up the drug. So plasma concentration falls and drug is withdrawn from highly perfused sites. So if site of action of drug was in one of the highly perfused organs, the redistribution results in termination of drug action. So for example, we can take thiopentosodium, it being a generalistic, short generalistic. So it is being a highly lipid soluble, enters brain very rapidly and then diffuse out of brain because it is highly lipid soluble and is taken up by fat and muscle tissues. And hence action of thiopentosodium is short-lived or it is very short acting. So to carry out the procedure, you need to repeat and administer continuous administration of drug over longer periods. So this constitutes the redistribution. So we have, let's summarize what we have learned. So we have seen what happens to drug after absorption, after drug is taken into various routes of administration. It gets absorbed and then it gets redistributed. So we have seen physiological barriers to drug distribution. And then we have discussed in detail about blood-brain barrier as well as placental barrier. And then we discussed in detail about special compartments for drug distribution. And then we have thrown some light on plasma protein and its clinical significance and added a note on operant volume distribution. And then we have discussed about redistribution. So that concludes my class. If at all you have any doubts, you can call me. Stay home, stay safe.